I do a joint clinic with Andrew Hudson on a weekly basis. Andy's one of the clinical oncology team at the Christie, and he started to use AI planning or AI methodologies for his planning. He said that it's so quick that it probably reduces his workload by about 10%. So just between you, Alison, and you, Isabel, just give us your thoughts on that.
Isabel, do you want to go first? Because I know you've you're using
Alison,
AI.
you go first, and then
Isabel,
I mean, I use we got AI contouring, so we get a supply of prostates, pelvic lymph nodes, and all the organs at risk in the pelvis. My experience is you need to look at them. They're not, you can't sort of, use them without scrutiny. The more difficult the anatomy is, the less useful they get. And if you just sort of copy, paste, and sign, it's not going to work. So I would kind of, I'm sure they will get better. I'm also sure, they will learn and improve and so on, because that's what AI can. But nevertheless, if you have a CT planning system, and that's what most of us use these in the moment, I don't think you will get rid of that job of looking at it. If it's very difficult anatomy, then I just contour without the AI structures. If it's very straightforward, I copy them with minor or no changes. Where the AI system, certainly the one we got, is useless is the base of the prostate. So seminal vesicles are fine, but often far too big or too long, contoured. And that kind of tricky a bit of the prostate and the base of the seminal vesicles, invariably they get wrong. If you give IV contrast, sometimes the arteries are actually contoured as bowel loops, particularly if you use oral contrast. So it's good, but to be dealt with caution.
Yeah, I think that's fair. And I think Julie was right to start with contouring. I think it's the biggest inaccuracy in what we do in radiotherapy. We've got so good with our physics, and our radiographers are so good at delivering the treatment, that we do need to focus now on reducing the variability of what we draw around. And we've seen from the quality assurance in our trials that there's a big variability in what people draw around for the prostate, and we don't know who's right and who's wrong, or whether it's just variation in different clinicians. But by reducing that variation, we have to converge on the right answer and reduce some of the side effects.
And there was a lot of talk about reducing the side effects. Clearly, that's important, and stratifying that and looking at tools in various aspects of assessing patients. We'll come back to that in a minute. But there are two aspects really. That one is the pre-existing symptomatology of the patient, bladder and bowel dysfunction that already exists, and how you compensate for that. And the second one is what you do with a patient who's a little bit more complicated. And we're seeing increasingly with the colorectal field that patients have had treatment, either radiotherapy with surgery, or they have a concomitant bowel tumour with a prostate tumour. And how do you handle that?
Yeah, I think we're not going to be out of a job soon, are we? I think that's the AI can't handle that kind of thing. So we're putting together two problems. It requires a lot of clinical oversight. And we definitely, like you, see a lot of patients with concomitant bowel and prostate cancer, and we have to treat the two together. So that's obviously something that's difficult to protocolize, and I think that relies on some experienced clinicians and the whole multidisciplinary team.
Yeah.
Okay.
I think, there's a lot of kind of angst, I think, around that clinicians' job being taken over by allied healthcare professionals and or the AI systems. The reality is they're all useful tools, but in the end, to pull that all together and make sensible decisions invariably requires experience and skills, which you not necessarily get from all those little bits of pieces which are useful for certain aspects of the job.
There's been a lot of work gone into looking at radiogenomics and predicting radiation toxicity with gene profiles. It strikes me that none of that's actually entered into clinical practice yet. So we don't have anything yet which is going to help you. David Durnley has put his hand up. David, good to see you or hear you.
That's very
and
good
we could see
you as well, Noel. And what a great meeting. I really congratulate all of you. It's I think been outstanding, and I really love the emphasis on teamwork. So Georgia, that was a nice talk. Thank you, particularly on teamwork. There were 2 points I was going to make. The first on AI. There was a marvelous set of Christmas lectures at the Royal Society aimed at teenagers, really, but I thought I'd watch it. And one of the big messages that came across was the huge volume of data that needs to go in to create good AI solutions. So it doesn't matter whether you're doing chess or Go or whatever. You need a mass of data to train the AI system. And I think one of the challenges, and I think this is very much related to Isabel, your comments on how difficult it was to do the outlining acceptably using AI. My strong suspicion is it hasn't got enough data. It hasn't got these difficult cases embedded into the algorithms. And of course, my guess is, correct me if I'm wrong, but different manufacturers will be doing their own thing, whereas actually they all need to do it together. They need to get this huge mass of expertly outlined cases and teach the AI to iterate round and round and round so it gets better and better and better. So I think if that could be achieved, and I don't know whether the audit committee could actually encourage this in some ways, that would be immensely helpful. And I think this would be a global, a great global benefit if it could be done. Regarding the radiogenomics, I've been involved with radiogenomics for best part of 30 years, I guess. It has been very depressing, Noel, because the output of it has been less than amazing. And if you look at the overlap of the different genetic constitutions that patients have, there is so much overlap that you really can't use it to define high risk and low risk groups, with very, very few exceptions. There are some very high risk patients, but it's a tiny proportion of the total. So I'm yeah, watch the space, but it's not anywhere like ready at the moment.
Thank you, David. Yeah, and so I think probably there's been a great focus on the very basic end rather than the high science end, which is fine. And Peter Barton has highlighted this. Peter's one of our patient representatives on the call about how science is great, but in practice it's not being implemented. So I want to come back and bring this down to a few things, but one in relation to how we assess patients. And so Tanya, your gold service is fantastic, no question. But clearly, out in the real world, if I might describe the world outside Guy's and St. Thomas's as the real world, if you'll forgive me, there has been an emphasis on the kind of self-help approach to this. So what we're hearing when we're looking at gene testing, well, we haven't got enough genetics people. When we think about cardiology testing, we haven't got enough cardiologists, and so on, and so it goes. But there are a couple of things which I thought were fantastic in your talk. One was a checklist idea, which is so straightforward. And it comes back to what Alison was talking about in her initial talk. I mean, we're so used to doing checklists in the operating room. That's just what we do. And why can't we have checklists in the outpatient clinic? They could be filled in. So I want you to just give us a comment on that. And Pauline Bagnall, I'm going to bring you in to just give us a steer on the practical application of this in a busy working practice up in the Northeast. So Tanya first, if you don't mind.
Yeah, so I think absolutely it can be done in terms of a checklist. And the tool I showed you that we use, 99% of patients do that independently in the waiting room in less than 6 minutes. So how many of you are seeing patients within 6 minutes of arrival? Probably not many. Now, that's the easy bit. Then you've got to do something with the blooming thing, because you don't want to just, and that was a lot of the findings of that original pilot, was where the pilot centres that did the questionnaires without support, and they made their own ones, they didn't know what the hell to do with it. They were like, oh my God, this person's got confusion. And so the main thing is, you don't have to be an expert in everything, and you don't have to have geriatricians, but it's about creating a framework of what to do next. So, you know, mobility issues, you don't need a geriatrician to say, well, you know, get a physio. Weight loss, systematically asking for weight loss. Theoretically, you don't need me to refer to a dietitian, but actually, because it's not been systematically asked about, you're missing a third, so you do. Now, but that's not me as a geriatrician, is about systems. So I agree with you, create systems and then frameworks to help the most junior member of the team treat it. You know, for example, iron deficiency anemia, you don't need me to treat that. And it isn't just the GIs, it's the head and necks often, it's the lung. So actually, or the gynae, there's so many things you could do for yourself without me. It's common sense medicine. So yes, I think systems will support. Using patients to help themselves is certainly something we should do more, particularly with the ADT patients, because, you know, over 50% are going to have ADT, and there are significant complication risks. So we're working with, at the moment, prostate, God, get the charity right, Prostate Cancer Research, that one, with their info pool about creating frameworks of our interventions for helping patients do things for themselves. So if they tick fatigue, then giving them the right information.
Thanks, Tanya. And so, Pauline, just give us your steer. Checklists, self-empowerment, how's that going to run in a clinic like yours?
So I would say you're right. The systems are not there to back up a checklist. Checklist is the easy bit to do. We can all do a checklist. But then what do we do with the information that we find? And then a lot of information, like we find a patient with iron deficiency anemia, patient has an osteoporosis risk. We would then ask the GPs to deal with that. And what we're finding is GPs haven't got time, and they're writing back and saying, you've identified this problem, it's your responsibility to deal with it. So the systems need to be there. And I think nurses, they are all about the whole patient, and we are very keen that patients get the best care, the best treatment. We will do what we can to bring that about, but we need the systems in place to support that.
But nonetheless, I mean, take your outpatient clinic, for example. If we were, let's say, collectively to produce a checklist and test it, that could be handed out to patients in the outpatient clinic. They could fill that in themselves, couldn't they?
Many could, but they're still going to bring it back and expect me to do something about what they've taken. And that's where I get stuck. So
if I could perhaps bring Georgia in here, because Georgia, you and Hassan Abedin, who's the urologist who you work closely with, have done a fantastic job in Dudley, no question about it. So it's the issue of the urologist acting as a physician, and of course urologists should act as physicians, as should clinical oncologists. But talk us through how it works in your clinic. I mean, let's take an example of anticoagulants. So many of the patients are on the warfarin and non-warfarin type anticoagulants, and those cross reactions are very significant. So how do you approach that in a clinic that's a busy district general hospital, effectively?
I think it's, again, bringing it back to the multidisciplinary team approach. So it's about sort of knowing what might be available to you, even, you know, in our busy district general hospital, and building those relationships so you can actually tap into those resources. So, you know, for example, being a cancer pharmacist, I work with hematology as well as oncology. So anticoag as a team isn't that far from me. So actually making some friends in the anticoagulation service has been particularly useful. When it comes to, you know, those troublesome interactions. with anticoagulants and so on. I think it's quite important to build that network, and as I've put in the comment box, utilize the Living With and Beyond Cancer services as well for the more social or sort of financial aspects of care that patients require in order to be able to support them better. But I think the single most important thing that I have capacity to do in my clinic is just those extra 2-3 minutes to listen what's important to them, because unless I do that, we don't pick on those things anyway.
Okay, could I just broaden out this a little further and bring in Joe Dodkins? Joe, you must be there somewhere. And there is this issue of patients not getting the treatment that they really perhaps deserve. It's very striking when looking at the notion of combination therapies, how few patients are actually getting it. So when we looked at docetaxel, 37%, I think was the highest figure it got to, and it's still about 55% are not getting a doublet therapy. And it's not just in the UK. This is an international problem. So talk us through this. What do we need to do?
Thank you, Noel. Yes, I mean, as I mentioned in the presentation, the international review of the literature has the numbers sort of between 9 and 38% of all eligible patients receiving these treatments. And in the landscape of us going from doublet to maybe triplet therapy, the chance that these patients are, a vast majority of them are potentially only receiving androgen deprivation therapy alone, sort of where the research is and where we are in the real world, there's sort of a huge chiasm here that we're not, there's a disconnect somewhere. And I think that's why we wanted to put, this issue front and center of the QI event and have speakers like Tanya, have speakers like Georgia, who I believe are team members who actually can bridge the gap here, who can make the difference, because as has been picked out within their presentations and within the panel discussion, there are ways of harnessing the MDT that may enable us to get these numbers up. And I obviously, seeing those numbers, the bar chart that I presented, it is a concern given all of the fantastic research that's being done in this area. And yet when we see the translation into access to treatments, it's just not happening. And the NPCA very much wants to do as much as we can to try and find out what the reasons are for those differences, not only in the underutilization, but also looking particularly around determinants of which groups in particular are getting this underutilization. I think probably what Tanya and Georgia have highlighted today is probably 2 examples of where we could do our very best work in terms of improving these numbers.
Of course, I'm completely biased being a urologist, because I feel that the urologists have been held back from prescribing stuff to the extent that they've stopped doing it, which is a real problem. And you, Georgia, in your group, you've shown just how that can be done. But in other groups, and we had a meeting last night where the Oxford team were there, and the Oxford urologists don't prescribe at all. So, Alison, can I come to you? What's your view of this? Do you think that prescribing should be the province of clin-oncs and to a lesser extent medical oncologists?
Oh, that's a loaded question.
Of course it is.
Thankfully, no, I don't. So we also have a multidisciplinary team prescribing these medications, not including a urologist at the moment, but I would have no problem with that. So we have prescribing pharmacists, a physician associate who helps assess the patients, and ANPs. So I think that's the only way in the NHS we're going to manage. There's so much AR targeted therapy to go round, and the indications are increasing. So I'm all in favour of the multidisciplinary team pitching in.
Because in one of your questions earlier on, you mentioned, or you asked, I don't think anybody answered, but is anybody still using docetaxel doublet?
Yeah.
And of course, people are still using docetaxel doublet, in my view, for very good reasons, actually. But that's going to be another topic.
Well, maybe we'll discuss that another time. I was keen to hear why people were using it, but no one replied. So maybe we'll take that offline.
Yeah, so why not deal with a bit of it here? What about the PARP story? Is that going to be affected by, what you use in first line is going to have an influence in what you use in second line?
Yeah, potentially. I guess my priority right now is to maximise quality of life for the first couple of years where men are well and can get on with life and go around the world. And we know that docetaxel has a significant hit to quality of life that lasts about 9 months. That's from the Stampede trial. And so my preference would be to keep men well and able to enjoy life for longer. And then we save docetaxel for longer. I accept your point about PARP. The landscape is changing, as Tanya said, that every 5 minutes we've got a new treatment in a different line. So I think it's hard to predict what will happen next.
Isabel, you've got your hand up. Oh, there are a couple of hands up. David, is your hand a new hand?
Mine
yours
is
an old
working.
hand?
I want to come back to the question of the multidisciplinary team and the urology team. I think part of the issue is that a lot of urology team work in DGHs, and invariably the way how the service is configured, that the oncologists come from a cancer center somewhere. So, and then you get this problem, who pays for what? So, in the moment the patients get referred to the cancer center for their doublet or triplet therapy. If the urologist would prescribe it, that would be fine as far as I'm concerned. Let's say they want to do they are kind of licensed to do the doublets, but the support for them is something which I would worry me. I'm not kind of quite as so they would need support from a pharmacist, support from the oncology team, and that needs to be properly resourced. And I mean, having worked with a DGH urologist for many years now, the pressure and workload they're under is often quite significant. I can't possibly see them doing even more. I mean, in the past they used to see these patients, but it really worried me at times because of their target patients get delayed, they're not getting seen in the clinic in appropriate intervals, and so on and so forth. The CNS nurses are overworked. They can't really help them much because they have too much work already. There isn't a pharmacist who would have the skills to do that sort of thing. And, they're not keen on taking on more work. So,
well, maybe,
I think it would be great if the urology teams could be kind of given the resources to do it, but that would require more manpower, more money on the DGH level where the urology units are, and there has been not necessarily the support for that.
Which is a very good point, Isabel, but I think that the evidence from the Dudley team is exactly that's what's happened, where there was a visiting oncologist. I think 2, Georgia, you had, but they were not GU oncologists, and there was a realization the patients weren't getting treated. And so
that's
the
right,
urologist actually took action.
That's right.
Georgia,
yeah, it's as a district general hospital, we have visiting oncologists, so we have that port of call to access to oncology advice at any time. We've got our acute oncology service within the hospital. We've got the triage service, but it wasn't enough. It simply was not enough to cover all of the patients, and it certainly is not enough, now with all of these newer lines of treatment. But I think what was also very important for me was to make sure that there was no health inequality. So if I'm receiving abiraterone under oncology, I should be treated and have access to all of the services in exactly the same way as I would if I was having it under urology. So access to acute oncology, triage, living with and beyond cancer, and so on. So I was just typing up in the chat to say that, really.
Yeah, thanks, Georgia. Alison, you're going to come back at us, I think.
Yeah, well, I was just going to pivot around because we're talking about breaking down barriers between professional roles. And I wondered if Sophie wanted to come in and just mention about how we've done that in radiotherapy in terms of contouring. Sophie, would you like to just speak to that point?
Yeah, definitely, Alison. And this is prior to AI taking over completely. But I work on the MR Linacs. Obviously, that's online adaptation daily for prostate cancer radiotherapy. And when that started, it's very resource intensive, requiring clinicians to be on set every day to contour the prostate live. And that wasn't sustainable in the long term, and we want to treat a significant number of prostate cancer patients on there. So we had to work hard to upskill our radiographers to take on this responsibility of contouring prostate patients in the online environment. So we put together a work package of training for the radiographers with offline contouring with clinicians, and then online review with clinicians. And then that resulted in a crossover service evaluation where we had doctors contour for half the patient's fractions and radiographers contour for the other half, and really showed comparable contouring results between both groups. It didn't have a significant impact on dose delivery to the patient. So I think working as a multidisciplinary team and learning, we learned a lot from the clinicians. We worked closely with the clinicians and our physicists to develop a strategy where radiographers could take on this role safely. And we still have, a backup. We have a doctor on call if there's a difficult, complicated case. The doctor will be around for fraction 1 of treatment in case there's any significant differences from what we're expecting on planning to treatment. But I think that it just allows us to build our experience and our competence as radiographers in order to develop a more streamlined radiotherapy service for our patients.
Thank you, Sophie. I'm going to bring in Pauline, but then I'm going to give the floor to Terence, by the way, who's our patient representative, or one of our patient representatives on the meeting, to give a view. So Pauline, the floor is yours.
I just wanted to throw another model into the mix, because we have no oncologists at our district general hospital for urology, and we are a hub and spoke with Newcastle. So our consultant urologists are visiting urologists. So for our prostate patients, we have about 4 sessions a week from visiting oncologists. Our MDT is at Newcastle, so we have very good working relationships with our oncologists, but all the support they give us is goodwill, and we're very lucky to have that, because if the team weren't as accessible as they are, we would really struggle.
And I think that's a very important point, isn't it? It may be one of the reasons, and I say one of the reasons, why the use of doublet therapy is so low, because I suspect it's happening in the big centres, but I suspect it's not happening in the DGHs. And just to re-emphasise that your point about systems being in place, and back to Tanya, GPs are very pushed, aren't they? Increasingly, there's a tendency to send patients back to GPs for follow-up, which may or may not be a good thing. I'm taken back to the original radiotherapy toxicity data, which we had from one of the main areas of England. And that particular group of clinical oncologists were treating their patients, sending them back to the GPs, never seeing them again. They had no idea they had a problem. And I think if we are to devolve some of this care, we need to be very careful about how we do it.